Hi everyone, in this video we're gonna talk about antiphospholipid syndrome. We're gonna cover everything you need for your basic and the clinical rotation, even for your board exam. So we're gonna start with definition first. For the definition, antiphospholipid syndrome is an autoantibody mediated acquired thrombophilia. In the pathogenesis, it will be more easy to understand this part here, but as you can see here, it's written that it's characterized by recurrent arterial and venous thrombosis, and with pregnancy morbidity. We're gonna talk about it. And there are two types. We have primary, which is not related to the other comorbidities, and it can be in association with other autoimmune disease, specifically systemic lupus erythematosus. So, we have another type is called catastrophic antiphospholipid syndrome, which is life-threatening condition. So in this type, we have rapidly progressive thromboembolic disease, and it can involve at the same time simultaneously 3 or even more organs. And as I said, the antibodies are directed against negatively charged phospholipids. And as I said before, in the pathogenesis, we're gonna cover this part. For example, including among, for example, cardiolipin, phosphocholine, and phosphatidylserine. For epidemiology, it's not really important to know this, but as it's written that we have around 5 cases per 100,000 persons per year, and antiphospholipid antibodies occurs in about 1 to 5% of the general population. It's not really important to memorize. By the way, the prevalence increases with age, so that's another thing to memorize. And that's all about epidemiology. So before we go before we talk about the pathogenesis of antiphospholipid syndrome, we're gonna briefly cover the beta-2 glycoprotein. So the beta-2 glycoprotein is a 43 kilodalton glycoprotein, and it consists of 326 amino acids. That's not important to memorize for sure, but the most important part here that the beta-2 glycoprotein consists of 5 domains, okay? And the 5th domain has positive charge, and as you know, the phospholipid has negative charge. So the domain 5 with positive charge, is suitable to interact with negatively charged phospholipids. And this part here is the main important for the pathogenesis of antiphospholipid antibody syndrome. So, and there is another thing to say about, that the VDRL test. So the treponema pallidum, which causes syphilis, in patients, for example, in patients with antiphospholipid syndrome, they have antibodies that those antibodies are able to recognize the cholesterol complexes in treponema pallidum, and that will lead to false positive serologic tests for syphilis. This is really important because in some patients who have antiphospholipid syndrome, some of them, or even maybe majority of patients, they will have a VDRL positive test, which, well, that doesn't mean that they have syphilis, but it just false positive serologic test. So for pathogenesis, okay, so let's say here we have a blood vessel, okay, and we have endothelial cells, okay. So in case, let's say that we have, as it's written here, surgery or trauma, okay? Anything can induces physical stress, okay? And infections, oxidative stress, which can lead to what? To damage to the endothelial cells or to the blood vessels. So in case of that can induce apoptosis of the blood vessels or vessel endothelial cells, and because of that the phospholipid will be released out, okay? So because, as I said before, the phospholipid has negative charge, so it will be released out, not because of the negative charge, but because of the apoptosis. So, and we have in the serum beta 2 glycoprotein, which can be found normally in the serum, okay? And for not only beta 2 glycoprotein, also we have a prothrombin, protein C and S, annexin 5, etc. Okay, they can be found in the serum, and they will be attached to the what, to the phospholipid, the negatively charged phospholipid. And as I said before, the positively charged, the domain 5 has positive charge, so it can be easily interacts with the phospholipid, the phospholipid. And because of that, we have now phospholipid beta 2 glycoprotein. Okay, now this is neoantigen, so it's antigen that can't be recognized as now it's recognized as foreign body. So now the antibodies will come and attack this immune complexes, or let's say because it will be because of its antigen, so antibodies will be formed as normal immune response. And there we have also complement activation, which can be also involved in the mechanism of antiphospholipid antibody syndrome. We have purplish discoloration of the skin, and it's because by the cause of this, this discoloration, we have a swelling of the venules, okay, due to obstruction of the capillaries by thrombi, okay. So let's say that we have here a capillary, okay, and we have here venules. So in case if we have a thrombus in this area, this part will be swollen, yeah, because there is no blood flow, right? Because of that, because of the swelling, we can have stasis of the blood. We can have this it can be less like purplish discoloration. That's the cause of livedo reticularis. And and we can have pulmonary embolism, superficial thrombophlebitis, and thrombosis in various sites. For example, in case of cardiac manifestations, we can have stroke, cardiac valve thickening or dysfunction, because the thrombosis can be like deposited on the valves. Lippmann sac vegetations, transient ischemic attack, myocardial ischemia, coronary bypass graft thrombosis, anything related, any thrombotic events. So leg ulcers, digital gangrene, arterial thrombosis, because it can involve in antiphospholipid syndrome. We have involved for artery, veins, venules, capillaries, etc. In the extremities, retinal artery thrombosis, ischemia of the visceral organs, avascular necrosis of bones, and especially in case of vascular necrosis of bone, we have especially for the femur, okay, and multi-infarcts, dementia. For nervous system manifestations, migraine, epilepsy, chorea, cerebellar ataxia, and transverse myelopathy. Musculoskeletal manifestations, arthritis specifically, if it is secondary for systemic lupus erythematosus, preeclampsia, eclampsia. And this part is really important here, because in the diagnosis, so we're gonna talk in more details about it in the diagnosis. So we have in case of the fetal loss, if it is before 10 weeks, it's called early fetal loss. If it is after that, it's called late fetal loss. And premature birth among the live births. Thrombocytopenia for sure. Thrombocytopenia because we have a platelet consumption. And autoimmune hemolytic anemia, because at the end it's autoimmune disease. Oh, sorry, it's not important. So in cases we have thrombosis and cerebral vascular. How to diagnose? So for this part is the most important part, okay? So for the diagnosis, we should have first cases of thrombosis, cerebral vascular accidents, in individuals less than 55 years of age. Okay. Pregnancy morbidity, and in the presence of livedo reticularis or thrombocytopenia. It's not okay if in case if we found pregnancy morbidity in the presence of livedo reticularis, oh, that means it's antiphospholipid. No, we have some manifestations here that we need to talk about. First, vascular thrombosis. In one or more we have one or more clinical episodes of arterial venous or small vessels thrombosis for any tissue or organ. Second, in case of the pregnancy morbidity, okay, first, if we have one or more unexplained deaths of morphologically normal fetus, okay, for example, there is no any genetic diseases, so this fetus has normal morphology, but we have unexplained death. Okay. So it can be after, as I said before here, it can be before 10 weeks or after 10 weeks. Or we can have one or more premature births of morphologically, again, normal neonate before 34 weeks of gestation, okay? It can be because of eclampsia or severe preeclampsia or placental insufficiency, because at the end it depends on the blood supply. And it can the third one is we have 3 or more unexplained consecutive spontaneous abortions, okay, before the 10th week of gestation. And in laboratory criteria, as I said, anticardiolipin or anti-beta-2 glycoprotein antibodies, okay. And by the way, we should do 2 tests, okay, for antiphospholipid or anti-beta-2 glycoproteins, and they have to be positive, okay, in 12 weeks apart. So we should do the first time beta-2 glycoprotein antibodies, and after 12 weeks, and it should be positive. And after 12 weeks, we should do again anti-beta-2 glycoprotein antibody test, and it should be positive. In that case, we can consider this patient has antiphospholipid syndrome, sorry. Okay, so for treatment, first, warfarin for life, okay? Warfarin is really important, and it's for achieve INR ranging from 2.5 to 3.5, okay? It can be given in combination with aspirin, 80 milligram of aspirin daily, okay? So we can, again, this is for the first line treatment. For pregnancy, if we can prevent, it can be prevented by low molecular weight heparin. As you know that warfarin is teratogenic. It can't be given for a pregnant woman, okay? And with aspirin, again, 80 milligram daily. So it can, by the way, we can give also IV immunoglobulins, 400 milligram per kilogram every day for 5 days, okay? It can be also prevent abortion, okay? But the glucocorticoids are not effective. So let's say that in some patients, okay, they have catastrophic antiphospholipid syndrome, okay, and they have recurrent thrombotic events despite the treatment. So they take warfarin and aspirin, and it's not effective. Even they take warfarin and aspirin, and it's not effective for them. So we can give them IV immunoglobulins, 400 milligram every day for 5 days. Okay, it can be helpful in this case. And in patients with, as I said, catastrophic antiphospholipid syndrome, they are in they are in intensive care unit, and in this case we can also, by the way, most of them, they are unable to receive warfarin, by the way, so we can give just low molecular weight heparin, okay. We can give low molecular weight heparin in this case. But in case of, for example, we have heparin induced thrombocytopenia, which is one of the adverse effects of heparin, we can give fondaparinux, okay, subcutaneous daily, or subcutaneous daily, and rivaroxaban, 10 milligram per os daily. They are effective in this case, in case of heparin induced thrombocytopenia. And at the end, we have here some pictures for catastrophic antiphospholipid syndrome. You can see the gangrene in the digitals here. Here also, here. And as I said, here is the livedo reticularis, and that's everything you need to know for antiphospholipid syndrome. And all the information here that I provided are from Harrison. So you can, like, I almost cover everything you need. So, but you can go back to Harrison and you will find everything easily to understand after watching this video. And thanks for watching. Goodbye.